Hello, can y'all hear me?
Yep.
Okay.
Yep.
Well, welcome again to the second talk for today of the Biocord Winter Conference. I'm Kraken, I am not FW, and so I'm introducing FW, who will be talking about the anatomy of the heart. I don't actually know anything about FW, so they'll have to introduce themselves.
Fine. Well, hello, I'm FW. I hope you can hear me. Kraken, can you?
Yep.
Yeah, I can
Okay.
hear you.
Fine. Okay. Yes, I'm FW. I'm from Germany. I'm a fourth-year medical student, and I thought about giving like a little speech or introduction, about the heart and its anatomy, because it's actually like something that affects all of us and still is quite overlooked in like our daily lives. So yeah, about this lecture, of course, I as well have to rely on literature, and the pictures I will use in this lecture are mostly from the Atlas of Anatomy, the Sabota. And some are also from a German website, Amboss, which serves for education of medical students. I did not have the time to label all of them individually, so I'm sorry for if any creators of these pictures will ever watch this. I am sorry, but yeah. And for knowledge-wise, I mainly use this anatomy book. It's a German anatomy book, Benninghoff. It's like the holy grail of anatomy books that's out there for all German students out there. So this is like probably if you ask most anatomy profs, they will say this is the best book. It's also very expensive, so I just borrowed it from a friend of mine. But yeah. This book, the Sabota, you will also find online on some questionable websites because it's also very expensive. So if you are not a medical student and want to find these, well, I'm not encouraging you to do it. I'm just telling you there are options like this. So let's get started. I won't talk about everything regarding the heart because it's of course an enormous field. So what I will focus on is of course the anatomy, the structure, the topography, so where is the heart and everything, and I will only scratch the physiology and the histology because both of these areas could have their own presentation, and it would take way too much time to explain everything. So also what I will leave out is the development, the fetal heart or the embryonal development as well, because again, it's very complicated and a whole different topic. So yeah, this is the heart as like a little model over here. You will often hear Greek or actually mostly Latin terms, but do not worry, they are quite self-explanatory and actually are often very similar to the English terminology. So you should actually understand everything even without like a direct translation. So the heart is also called the core or cardia in Greek. Core is the Latin term. It is a muscle, a circulation pump, so to say. It has an atrium and a ventriculus on the left and the right side. So it has in total 4 chambers. Here, this is the right atrium, the right ventricle, the left atrium, and the left ventricle. So as you can see over here, it's already a little bit confusing because mostly people think that, okay, in pictures, if it's a blue vessel, it's a vein, and if it's a red vessel, it's an artery. This is a misconception because actually an artery and when you want to normally paint something blue or red are totally different, rely on totally different definitions. So the vena cava superior and inferior is this thing over here. This is the superior and this is the inferior one. So what is a vein actually? A vein is defined by it will lead blood towards the heart. Of course, most of the time you want to lead blood towards the heart if it's desoxygenized, and then you would paint it in a blue way. But this is not always the case. So over here we have the venae. Oh, sorry. Over here we have the venae pulmonalis, and these are painted red because they also lead blood towards the left atrium, but this time it's enriched with oxygen because these venae directly come from the lungs and bring the enriched oxygen towards the heart, and then the heart will pump it into the body circuit to be consumed. The truncus pulmonalis, basically, it is an artery and will be called the arteriae pulmonalis later on, once it splits, is painted blue because it's again carries low oxygen blood towards the lung, and but since it carries blood away from the heart, it's an artery. And finally, we have the aorta. It's like a very big vessel, the main blood vessel in your body. And I won't describe everything here. It's of course way too much, but like the main differentiation here is the pars ascendens aortae or the aorta ascendens. Then it changes into like this arcus aortae, which will lead around the heart that would normally be here, and then dives down next to the spine on the left side, because whenever you look at a patient or like on a picture, you will look at it like a patient standing in front of you. So this is the left side, this is the right side. So on the left side, we have next to the spine the pars thoracica aortae, or the aorta thoracica, also called the aorta descendens. Because, of course, it's in the thorax, and once it passes the diaphragm over here, it will be called the pars abdominalis aortae, since we are in the abdomen. So yeah, I hope I won't get too hyped about this right now because sometimes my English will be slipping. I hope you can overlook this. Yeah. So we should get started with the topography, so you actually know where we are and what is surrounding the heart. Because of course, most people don't even know that, for example, we have a thymus over here. This is this organ, and it plays a major role in your immune system and its regulation. And it lies directly on top of the heart over here. So, but most people don't even know this. I didn't know before I started studying anatomy, at least. And on the left and the right side, we have the lung, surrounded by the pleura, which is basically like an invaginated sac, which is filled with like a little bit of fluid to keep the lung stabilized and keeping it from like falling together. And in the middle, here we have actually the heart. And here you can actually see that already the heart is like in the very middle located, right beneath your sternum, like the breastbone, and then only peaks with its apex to the left side and actually pushes away the left lung a little bit, leaving the stent over here, which means or is called the incisura cardiaca. Whenever you see something called pulmo, it's literally just the Latin term for lung. So yeah, we will come back to this picture in a bit. This is just like to give you an overview. The pericardium, is just the name for the sac surrounding the heart. So this is the heart, even if it's called pericardium over here. So we will start with the mediastinum. It's the word which stems from quod per medium quod, so Latin again. It's basically the area next or in between the lung, or surrounded by the two lungs, filled with connective tissue and several organs. So there is a mediastinum superius and a mediastinum inferius. And the mediastinum inferius is once again split up into mediastinum anterius, medius, and posterius, which you can see over here. So here we have the posterius, with this as the aorta, the esophagus, vena azygos and hemiazygos, and here we have the heart, and here we have the mediastinum anterius, where not really much is located. I actually have found that these two little vessels over here, the arteria and venae thoracica interne, are sometimes counted towards, sometimes are called to be within this mediastinum anterius, but sometimes not. So in anatomy, sometimes the profs will say something different than the other prof, because why not? Because it's not easy enough. Now we have like a big overview about everything you basically saw over here. You don't have to know everything, and I won't dive into everything over here. It's just another explanation. If you're looking at this on the recorded video, you can as well pause the video and read through all of it. Even like the muscles over here are all described, but we will again focus on the heart. We have, of course, here the lungs, and now we can also see that this over here is the nervus vagus sinister. Sinister is the Latin term for left, and dexter is, or dextrum, is the Latin term for right. So the nervus vagus is like a very, very important nerve into your body. It will, for example, carry the innervation for the esophagus and most of your internal organs. Right here we have some of the the atrium sinistrum, for example. Over here, then of course the ventriculus sinistrum, ventriculus sinister, the atrium dextrum, and the ventriculus dextrum. Over here we can already see that these are the walls between the two spaces of the atrium sinistrum and the ventriculus. And now we have like in real life body. Of course, like this is a dead one, and this is made up in a slice. So you look normally, if whenever you have like such a slice, you look from the bottom of a human towards the head of a human. It's often a misconception that you look from above, you look from beneath. Just to keep this in mind. This is, of course, again, the left side. This is the right side of the body. Here we have the esophagus, with the next to it the aorta. And the aorta on this side here is actually like a very good indicator that you're laying this picture on the right side, like on the correct side, because it's always on the left, or in this case, like anatomically speaking, on the left side. Then we continue with the Xenos Coronarius, which is part, together with the number D, the arteria coronaria dextra, part of the blood vessels that supply the heart itself, also called the vasa privata. And at last we have here, which also actually refers to this structure, the tricuspidal valve. So basically the valve between the the right and the right atrium and the right ventricle. But we will talk about these valves later on quite a bit. So this is just like a first picture how it looks like in real life. So, but now generally more about the heart again. To give you an overview, this is an X-ray of the heart, of course, with a little bit of help to show you what is what. I didn't draw this myself, but it's very good. You have the heart here. Again, you can see it's really located in the middle of your body, and then takes a turn to the left side, because most people actually think that the heart is just in, like the left of your chest, but it's rather in the middle. So wait a second. Okay. The heart normally weighs about 300 grams in males and 250 grams in females, but it varies quite a bit because it depends on how much training, like or how much sport you do. The more sport you do, the bigger the heart gets. But this has like a maximum level, a critical mass at 500 grams, because afterwards your vasa privata have difficulties actually supplying the muscle tissue with blood. So you can't really sustain the muscle tissue anymore. And when it gets bigger than that, which can be because of pathological causes, such as like an insufficient heart, it can get much bigger because it tries to circumvent, like for example, if your heart has to work much more to get the same amount of blood out, it tries to circumvent it by like hypertrophy, but at a certain point, of course, it's just unhealthy. It can get up to 1,100 grams, a cor bovinum, which quite literally means what it looks like. This would be like a clinical case of a cor bovinum. What is interesting is the heart cells only go through a hypertrophy, so the cells itself get larger and do not like divide, which would be a hyperplasia. So you don't necessarily have much more cells, but just bigger cells. This kind of stuff is also called cardiomegaly, which is just another name for it. Normally, it has like a size of a fist and should be like 12 centimeters from basis to apex. The apex would be over here, and the basis over here. Though this is of course much larger than 12 centimeters. This is like the clinical ill version. You also divide the heart into several fascias. The fascia sternocostallis, which is basically just the side towards the sternum and like the ribs. The fascia diaphragmatica, which is towards the diaphragm. And the fascia pulmonalis, which is on the left and the right side, the left and the right side of the body towards the lung, facing towards the lung. Okay, so this is like a modeled version of a healthy heart. The external view of it. Okay. The yellow stuff you see over here is actually just fat, so you don't have to get it confused. It's fatty tissue that serves as a shock absorber and to stabilize everything. Over here, you can see the atrium dextrum with the auricula dextra. The auricula dextra and sinistra are basically just like little sacs of the atrium that peek around towards the anterior side. On this side here, from the ventral or anterior view, you only see like this little auricula from the left atrium. On this, from the posterior view or distal view, you can see actually like the left atrium as well, more or less at least. But you shouldn't get confused. Down here is already the atrium dextrum. So here we have the right ventricle, this part, and you can see the limitations of it over here. This is the sulcus coronarius, and this is the sulcus interventricularis anterior, which is quite literally what the name tells you. So it's like a little space between the ventricles on the anterior side of it. Again, Latin is quite self-explanatory, but yeah, it sounds much more scary than it actually is. In these sulcus, normally are blood vessels located. These are the vasa privata that I already mentioned. We will talk about these in the end of the presentation as well, much more in detail. And what I will just mention here is the Xenos Coronarius, which is basically the spot where all the venous blood of the vasa privata, of the coronary blood vessels, flow into the right ventricle. And although it looks like here as it would flow into the left atrium and not the right atrium, this is like a misconception, because over here you can actually already see the vena cava inferior, and as we have seen in a previous picture, this vena cava inferior will lead into the atrium dextrum, and this Xenos coronarius will follow it. So I think, yeah, only thing I would also mention over here is this sac, which is what I already explained a little bit, the pericardium. So it's again like a sac that is an invaginated structure going all around the heart, and is filled with a little bit of liquid. It works as like a shock absorber and to lower the weight of the heart. Okay. Oh yeah, and over here, this is called the apex, just like because of its form. Okay, now we will speak about this part of this picture specifically. It's called the Trigonum pericardiacum, and it's actually quite important for several reasons. This is a space where you would normally use an intracardial injection. So if you have like ever watched any action movie where someone is dying, they are like pulling out a big ass needle and push it through through the chest. This is not very healthy to say at least, because like the way they do it in any movies is like straight through your sternum, and let's just say a needle versus a bone is normally very optimistic, to say at least. But it has some truth to it, because this space over here is actually like where you can pull a needle through the heart into the right ventricle without damaging the pleura parietalis. And this is quite important, because should you damage the pleura or even the lung, you can cause or risk that the lung deflates entirely and collapses, which is, let's just say, bad. Yes. So where can we locate this? Someone is muted, I think. I just heard myself twice, but yeah, now it's gone. Okay, everything's fine. Okay, where is it located? You can find this trigonum pericardiacum beneath the fourth rib, and you would normally try to locate it, like if you want to do this injection into the intracardial injection, you would go next to your sternum, the breastbone, and beneath the fourth or fifth rib, and there you can do it. So this would be, of course, something that's still very risky, because you have to pierce through the pericardium and into your heart, which is still not an easy procedure. But it's also interesting for another fact, because here, if you do a percussion, it's like this classic examination trick of, or procedure rather, of any doctor, where he lays like one finger on your chest and then knocks with the knuckle of his other finger against it and tries to listen to the sound of it, because of the different properties of your tissues. And this is specifically the case here because of the so-called cardiac dullness. Since if you breathe in, your lungs will inflate and push themselves up to the front of the pleura parietalis, so over here, but they won't go any further. So the trigonum pericardiacum will still be free. So you can examine actually where the lungs will stop by doing a percussion. So if you listen to the percussion, it's a little bit tricky. You can try yourself, just like laying a finger on your chest, and like it has to be very straightened, the finger, and then you knock against it with your knuckle. It takes a little bit of practice to do it correct, but if you breathe in, you can actually hear the difference should you do the percussion over here and should you do the percussion over here. Because if you do it over or on top of the lung, you will hear a very resonating sound, because of course this is in a space filled with air, so the sound will resonate. Should you do it above the heart, though, it will be a very dull sound, which led with so that's why it's called the cardiac dullness. And yeah, that's like a very easy and quick examination that does not cause any harm to the patient. That's why it's actually still a very good one. More important is actually, but more important is the auscultation. with a stethoscope. And this is, so the stethoscope can be placed on several spots here. I will explain it in a second. And again, this is a very, very important measure because it's not invasive. You don't have any risk for the patient at all. Even an X-ray is still some risk and some harm to the patient, which you try to avoid. And in fact, an auscultation will tell you quite a bit already about the condition of, for example, the heart. To give you an example, actually, I will try to open, I will end the stream for 1 second and open a video that I have, and it should work. I already tested it. I hope this won't cause any problems for Kraken. So wait a second. Okay, so yes, I have it. Nice. Okay. Now this will be a sound. First, you will hear something called a heart sound, which is physiological and healthy. This is how it should sound. And later on in the video, it just takes like a few seconds, 30 seconds in total, you will hear something called a heart murmur. This is what is caused by the different blood flow, and I will explain later what exactly causes it, and you will try to like differ the different sounds, and it's quite obvious. I will just play it. Okay, so I hope everything worked now and you actually heard this. I will now switch back to the other stream. Wait a second. No, not that way. Okay. Where is it? There. Okay. Back to the heart lecture. Take it like this, and now... so complicated. Okay, now. Fine. Yeah, as you could hear, this was like a very different sound. This normal, like initial badump, 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 badump. This is like actually the sound that's totally healthy, and you know it probably from yourself. And it's caused by it's caused by your valves like slapping together. The first sound, like badump, like the ba in this case, is basically when your systole, so when your heart contracts and presses out the blood out of your body. The valves between, wait, can I find it over here? The valves between the atrium and the ventricle will slap together because of the difference in pressure between the atrium and the ventricle. Because the ventricle will contract during the systole and push the blood normally to out of your heart into the blood vessels, and to prevent that the blood will just take the way backwards, we have like valves in between that will slap together, and this is like the first heart sound you heard, and then the badum is the second heart sound, and this is at the start of the diastole, which is called Someone isn't muted, which is caused by the blood flowing back. Like when you're okay. Let's try again. When the systole is over, the pressure in your ventricle is of course lower now than the pressure in your aorta. So the blood in the aorta will try to flow back, and this is like called the retrograde flow of the blood. And at this point, the valves over here will smack again together, and the abrupt, sudden stop of the blood flow backwards. This is what causes the second sound. Now, the unhealthy version of it, what you heard on the second half of the video, the heart murmur, is different from this. This would be if the heart would... Wait a second, I have a good picture of it. This would be an aortic valve stenosis. So this is the real life heart, like the aortic valve actually. And also this is with stenosis already included. So what does it mean? A stenosis means that you have like over here it's like a little bit, and here's like a very, very extreme example. For example, a calcification of the valve with cause it is and the cause of it, or like what happens then is that your valve can't open anymore, or like at least not sufficient anymore. And the problem now is that you still have to pump the blood through it. And your heart can only to some extent, like with more muscle tissue or bigger muscle tissue, try to push just harder, but at some point it just won't work anymore. And if you have like ever squeezed something through such like a small space, of course it's much more turbulence once you pressure it through such a tiny hole. And this causes like the sound, this murmur you heard. Yes. So basically that's it. You have over here also another X-ray. And because a calcification is much more denser than the surrounding tissue, you can see it here like on these white particles. And here's also an histology view of it. This should be like a calcification over here. Here's again like just a picture of a normal heart, how it should be working normally with an aortic valve. So it just flows out. And here's it with a calcification. There are a lot of different valve illnesses. But like if I try to like explain everything, we would sit for 5 days here. It's like very a lot of stuff. You can with the auscultation, you would try to use like these different spots for different valves, because like here you have the aortic valve. Here you would have the pulmonic valves. Sorry. And these two are actually, I'm still not sure why they have 2 points over here, but these two can be used for the tricuspid valve. And on the final bits, you have here down at the apex the mitral valve. We will talk about the valves and their specific structure and what is what later on. So if you don't understand everything right now, it's okay, don't worry. Okay. I would take a little break, like 2 minutes now, and just drink a little bit, and then we would continue with the interior view of the heart, and then go on with the valves, the skeleton of the heart, and everything else. We won't talk that much about histology, but we will I will give a little input about it, just like the very, very basic overview, because otherwise it would take a little bit too long. Okay, see you soon. I made a little timer so you know when I will start again. Okay, let's go. Um, as I said, we will continue now with the interior view of the heart. I will, like, I've already seen some questions in the chat, but I think I will rather answer them in the end. At least if I can. If you ask me about any symptoms of yours, I'm sorry, but that's a big no-no for me. So yeah, but to get back to the presentation, first of all, we have a view of the the right atrium and the right ventricle. And we will actually start over here with the entrance of the Vena Cava inferior and the Vena Cava superior. You can see this over here and here. Then we have the Valvular Venae Cavae inferioris. I know it's a very long name. There is another name because the guy who found this or like described it as well. And I hope I call it the right way because otherwise probably the Italians you will crucify me, Eustachian Valve, it's called. I'm sorry, I have no idea how to pronounce this name. So the valvula Vena Cava inferioris is also called the Eustachian valve. Many anatomists have this ego trip to just call a structure by their own name. This is no exception, and it's from the anatomist Bartolomeo Eustachi, who lived and this shows and actually depicts how old this stuff is. This is from 1520 to 1570, so it's very, very old. Most of the science stuff we will talk about on the servers probably I don't know, perhaps 50 years at maximum. This is 300 years old. Wait, no, 500 years. Sorry. Yes, I already mentioned math isn't my strongest subject. The valvula Vena Cava inferioris in general is a remnant of a structure that is only relevant during the fetal period. So when you're still unborn, the heart actually looks very different, and generally the blood circuit is quite different because, of course, you don't have any air to breathe, so you don't need the blood to flow through your lungs first, which would be a huge waste of energy, since all the oxygen you get as a fetus is from the mother. And so the heart is also structured very differently, and you can see some of the remnants of it. Again, I will not dive into the embryology in detail because a lot, but we will talk about some of the remnants that we can see over here. So first of all, we have the valvula Vena Cava inferioris, which is this thing over here. And secondly, we have the Fossa Ovalis with the limbus fossae ovalis over here. The limbus fossae ovalis is also called sorry, I have no idea how to pronounce this name. It also has a name. You can look it up. Normally you won't use this one actually, but I found it, and yeah. So the fossa ovalis is actually a remnant of a connection from the right atrium to the left atrium, so between the atriums, because you want to in the fetus, the blood flows from each atrium to the other, and has a direct connection, which of course you don't want at all in the adult heart, because otherwise you would have the desoxygenized blood mixed up with the oxygenized blood, and this does happen. It's a mistake that sometimes occurs, and depending on how big it is, I think I even read a study that there's a small space over here that sometimes, actually 20% of the time, still exists, but it's so minor that it's basically inconsequential. But should for example the fossa ovalis still be open, you would have a lot of problems, since your entire body would be craving for oxygen that's simply not there, because instead of flowing through the lung, it would directly flow into your body circuit again, which is a big no-no. Over here you have again the Ostium Xenos Coronarius, which is basically just the opening of the Xenos Coronarius, which we already seen in one of the pictures with where the venous blood of the coronary blood vessels flow back into the heart, into the atrium. Over here we also have the valvular Xenos Coronarius. It's again like a little remnant. It's these structures over here, together with the Trodaris tendon. You can't really see over here. It should be like a continuation of the valvula Vena Cava inferioris, but it's difficult to actually see here, the Trodaris tendon. These two structures, together with the valva atrioventricularis dextra, so the valve between the atrium and the ventricle, form this triangle, the Koch's triangle. Sorry, and it's a localization for one specific structure, which we will later on talk about. It's the atrioventricular nodus atrioventricularis. Sorry, nodus atrioventricularis. It's one of the stations for the innervation of the heart. We will talk about this later on, and then you will actually see what I mean. And this, just remember this name, Koch's triangle. We will see it again later on. So yeah, what else can we see? We do see here some of the muscles. Most of this septum is actually just connective tissue and without any muscle tissue. So it's like the septum between the right and the left atrium. And over here you have these muscles, the musculi pectinati. They got their name because like they kind of reminded the people who saw them or described them first of a comb. I don't see that, but okay, I guess. Yeah. Beside that, I think regarding the atrium, that's it. The foramina venarum minimarum, for example, are just like little vessels that stem from the coronary blood vessels and that go directly circumventing the Xenos Coronarius, but they are not really relevant right now. So over here we have like the valva atrioventricularis dextra. Again, this is the valve preventing the blood from the ventricle to flow back into the atrium during the systole. And I think I will switch to, yeah, here's actually a very nice picture as well. Sorry. Okay. So you have the Ostium atrioventricularis dextrum. Basically, so the opening between atrium and ventricle. And over here you would have the Ostium truncipulmonalis. And in between, which you can't see here, but is described, is the crista supraventricularis, which just helps leading the blood from atrium towards the ventricle, towards the ostium truncipulmonalis. What's also very interesting is these trabeculae carnae. They have like a very diffuse structure, which can also be seen over here. This is like from the actual heart, and they don't really have like a very special structure, but there's one example that's different. It's the moderator band, also called trabecula septomarginalis, and that's actually something that maybe some of you might have heard of, because it's described by the famous Leonardo da Vinci. He was the one who described this one. The moderator band has in fact a very special function. It leads the innervation that would normally come from or through the septum intraventricularis, so the septum that divides the left and the right ventricle from each other. The innervation follows this pathway, and the moderator band kind of gives it like a shortcut towards these muscles over here. These three muscles, which are called the musculi papillari. They are connected with the valve through chordae tendinae, which is basically just connective tissue, but it's very, very important actually to have these, because due to this shortcut, these muscles will get innervated before the rest of the ventricle and give the valve some stability through the chordae, so that once the blood pushes backwards into, and would normally without the valve push through the atrium back into the veins, which is bad. So these valves must be protected from just like slapping through this area. Like they should close up over here, but if you don't have these chordae tendinae stabilizing them, they would just flap over because they have no stability otherwise. This does happen sometimes, that these chordae tendinae rupture. This can happen if you have, for example, a heart attack and the the musculi papillari get damaged as well. Then this would not function anymore, and the tricuspid valve would just flap over and cause like acute an acute insufficiency of this valve. So let's move on. 1 second. Yeah, over here you already see the left and the right, the left atrium and ventricle. We will switch to this picture. It's much less interesting stuff than on the other side. But again, we can see here the other side of the corresponding valvular foraminis ovalis, which was again, the connection between the right and the left atrium before it closed up after birth. As well, we can see here the vena pulmonalis sinistra, inferior, superior, and pulmonalis dextrae. Actually, it's usually 4 of them, but it doesn't have to be. Actually, sometimes it's just like 1, or sometimes it's 3 of each. It varies quite heavily. It's not something that causes or has to cause any problems. It's just something that, for example, if you're a surgeon, you have to keep in mind that this can vary, so you don't hurt the patient in any way because you somehow cut the wrong vessel because you thought it was a different one. Generally, this is like a rule in anatomy. Blood vessels do vary. They do vary very often. Vary. And this is also the case for, like, of course, the major aorta should not vary at all, but even this one can differ from person to person a little bit. Okay, back to the heart. Here we can see again the auricula sinistra peeking around what would normally here be the aorta. And otherwise we have like these musculi papillari again, with the chordae tendinae connected with the valva atrioventricularis sinistra, or the mitral valve. Okay, so what you also can see here is actually, or maybe you have actually noticed, this wall of the ventricle is much thicker than the wall of the right ventricle. This is of course because you have a different amount of pressure in the body circuit and the circuit of the lung. The circuit of the lung, or like the small circuit also called, on the right, from the right ventricle into the lungs, only needs a pressure of like 15 to 28 millimeter HD. And on the left side, you need a much higher pressure. It's like the normal systole pressure with 90 to 140 millimeter HD. So yeah, about 4 times as much, and thus the ventricle is, even in a normal healthy heart, much thicker than on the right side. Okay, I think that it's it for this slide. We have again here the apex caudace, and again the trabecular carne are the same as in the right ventricle. Okay, now we will switch to the heart walls and the cardiac skeleton. I have once in a while actually mentioned the cardiac skeleton perhaps already. We will start with this and then move on to the heart walls. The cardiac skeleton in function actually serves as an isolation, because you do not want the innervation to just freely roam the heart. The thing is, the muscle tissue of the heart does in fact transport is a conductor, if that's the correct term for it. So it does serve, if you have like a muscle tissue of the heart, there will be a current flowing through it, and you want to prevent it from just freely roaming from the atrium towards the ventricle. Right now we are looking from above onto the two sides of the ventricle. So here would be like, actually this is like one example where it's the other way around. I managed to find that out later on as well. It's a little bit confusing. This time this is the left side, this is the right side. Just keep that in mind, because normally, as I mentioned, this should be left and this should be right, but here it's a little bit confusing. So you want to prevent that from the atrium any kind of innervation can reach the ventricle without this little point over here. We will talk about the innervation later on, as again a little bit more in detail, which is important now. You have here the heart skeleton, which is mostly made out of collagen. And if you go a little bit farther away, around here or here, it's more made out of like fatty tissue, or also called fibroadipose tissue. And this would be like to prevent the innervation passing through these little areas over here. It's also called the annulus fibrosus dexter and sinister. So, in the middle we have, like here, over here, the trigonum fibrosum dextrum. And this is made out of fibrocartilage, or fibrous cartilage-like tissue, more or less. And what is interesting, and which I didn't know until yesterday, is that in ruminant animals, like for example cows, this actually is bone tissue. And I have no idea why, but yeah, they have basically a hard bone. From this point out downwards and upwards would be like the septum intraventricularis, like separating the two ventricles from each other. And over here you have the aortic ring and the pulmonary ring. Basically, like the opening from the ventricle, from the left ventricle and the right ventricle into their respective blood vessel. And yeah, it's over here you have again the Trodaris tendon. We will leave out this one a little bit. I don't even know why it's here again. I will just take it. And we will focus on the aortic and pulmonary ring. So sorry. So yeah, you can see that this pulmonary ring is again like serves to isolate the two ventricles from the atrium, and in this case, you can see, or it is the fact that the tissue, the connective tissue over here, will duplicate itself and form as well in a serrated pattern the aortic and pulmonary valves. They are also called semilunar walls. We have already seen them in the picture with the calcification of an aortic valve. The singular thing over here, they are like shaped in little pockets and are sometimes also called valvula semilunaris. Sorry, valvula semilunaris. And yeah, I think that's basically it. There are each 3 of them, and these are actually very different from the valva mitralis and the valva tricuspidalis. And these would be like the openings from the atrium towards the ventricle. These valves are made out of, again, of course, a little bit of connective tissue, but also it's a duplication of the most inner layer, the endocard, which like serves, like is in the most inner layer of, for example, the both ventricle and atrium, and it has like a duplication which then leads towards these valves and basically forms them. Over here we have like two of them, and here we have 3. That's why it's also called the valva tricuspidalis with 3, and mitralis basically means referring to the 2 valves and 3 valves. Okay, here again it's a little bit better described. Valva aortae with a valvula semilunaris each year, and the valva mitralis over here. These are also called cuspis, like the individual thingies over here are each called cuspis, and that's why it like differs a little bit from the valva aortae and the valva tronchipulmonalis. But I think that's basically it. I have like the feeling that this might be a little bit overwhelming right now, so if you have any questions about that, or later, if I haven't explained something sufficiently, feel free to ask. I hope I can answer them. Another thing, and I had to use a German graphic over here actually. It's not very beautiful, but it was actually the only graphic I could find regarding this topic, which is confusing to me because in German lecture it's like literature, it's very prominent and like always praised. It's very important, but I couldn't find anything online. It's regarding the valvular plane, and it describes a very smart function because you want to, of course, to optimize the work that your heart is doing, and like preventing it from overworking itself. And here we have an anatomical feature that like shows how smart our body is, at least in some points, built. So should your heart contract, the muscle will pull actually the valvular plane, or like where you all the valves are like in one plane, and this connective tissue together with the heart skeleton will be pulled toward the apex. And since this is closed, you will cause an under pressure over here in the atrium, and thus suck in blood into the atrium without any extra work. And then in the diastole, when the heart is like not contracting anymore, the valvular plane will open and go back into its original state, and basically take in this extra space over here of blood without any work at all, and filling the ventricle without any contraction. And only after this, so already in the diastole, your ventricle is filling up, and only after this, the atrium will contract itself and press a little bit of extra blood into the ventricle as well. But the thing is, actually, I think like 70% or something like that of the blood in your ventricle is pulled in by this mechanism. So the contraction of the atrium is in fact secondary. And this is much more interesting. And this is like solely an anatomical feature that works to minimize any extra work. Okay. Now to a little bit of histology. We only have 3 slides. Again, this is very complex, very, very complex stuff. And histology in general just needs its own presentation. So I will just scratch the surface here so you know what we are talking about, and then move on. We have several different layers in the heart wall. We have, first of all, the heart sac, like what we have already seen, the parietal pericardium, which is here, which is again like a duplication, and the inner part of it, the visceral pericardium, lies directly on the myocardium, so the muscle, and this is like connected with each other. And the pericardial cavity in between here is filled with the fluid produced by the visceral pericardium. This fluid can, of course, like be filled with can cause any kind of problematics. Should, like, for example, flow blood into it, because over here you can see that the duplication does meet each other, like connects with the major blood vessels, and should like any of these rupture, blood can enter this pericardial cavity, and this can cause, of course, it's like if it's just a little bit, it's okay, nobody cares, and it will get absorbed. But at a certain point, of course, it's like pressuring, like it applies an extra amount of pressure against the heart, and like is a problem, so that the heart can't really work anymore. And what can also happen, and I really like the German term for it, because it's like, I hope you understand Panzer. It's like, Panzerfaust and everything. It's like when the outer, the parietal pericardium connects with the visceral pericardium, it can sometimes grow together, and thus leading to basically the heart failing over time. It's very, very bad, and yeah, but this is called in German a Panzerherz, so Panzer heart. And yeah, but back to the topic. The next layer over here would be the myocardium, which is actually the muscle of the heart. And then we have the endocardium, which is like the inner layer that is very like smooth, so that none of the blood, none of the blood cells stick to the walls or cause any problems. We have over here like another picture, so you can actually see what I mean. You have here the pericardium, serosum with the lamina parietalis. This is this blue thingy. And here is like the visceral layer. Visceral just means that it lays on the organ. Over here is just the equivalent with the lung, but we will skip this. We don't care about the lung. Um, so yeah, and this is just like so you can see like there's a little space in between, which will be usually filled with a little bit of fluid. Okay, and for the last bit we have like an actual microscope picture. With over here would be like the ventricle, the inner ventricle, and here we have the endocardium. Here would be like a single layer of skin cells, epithelium, and then we have like a lamina propria and everything. But again, you don't have to know these terms until there's any special lecture for histology. Diving into this would be way too much. One special thing I would like to mention, because it's actually relevant for the next topic we will talk about, are these Pukinia fibers. These are modified muscle cells. So they function as very special conductors for the innervation of the heart. Because although the myocardium or the myocytes do conduct the electricity, or rather the current as well, they are much slower than these Pukinia fibers, and it's a way to regulate what and where everything can contract at the same time. Okay. And now, as I already started, we will talk about the electrical stimulation and conduction system of the heart. Here again, there's a lot to talk about regarding physiology. So we will rather just scratch the surface here. But I think it's important to at least talk about it in general. We have several structures that we can already see. 1 second. You have here the nodus sinoatrialis, which is basically the pacemaker of your heart. Your heart does not need any connection to any, or it needs like in a real life body, but technically your heart does beat on its own without any connection to your brain or any other connection to a special nerve. It has its own little pacemaker. This is the nodus sinoatrialis, and it leads with these little fibers down towards the atrium, around the atrium, and toward the nodus atrioventricularis, which we already mentioned is in the Koch's triangle. And so the thing is, you have like this very special rhythm of the heart, like first contraction of the atrium and then the contraction of the ventricle, because logically you want the blood first to contract in the atrium into the ventricle, and from the ventricle into the respective blood vessel. And to make sure that this actually is how it works, you need another little pacemaker over here, the nodus atrioventricularis, which has a very complex three-dimensional structure, and like, holy shit, I tried to read into it and I was blown away, but yeah. The function of it is, first of all, it is its own pacemaker as well. So even if the nodus sinoatrialis would die for some reason, it would not function anymore. Technically, you don't need them. The nodus atrioventricularis can be enough for your heart to work. The problem here is that it is much slower because it's in its normal function. The nodus sinoatrialis will send its signal. The atrium will contract. And now to circumvent that the ventricle contracts at the same time, the nodus atrioventricularis will block, or rather slow down, the innervation, and then it can pass on through the fasciculus atrioventricularis, which is also called the His bundle, which I think we have talked about over here. And again, this His bundle is special because it's the only way of this electric current to pass the heart skeleton, which normally serves as an isolation. Now we have the crus sinistrum and the crus dextrum, sometimes also named by its discoverer Tavara. And these two are located in the septum intraventriculare over here and go downwards to the ventricle on each side. And over here, yeah, you have how is it called? The rami subendocardialis, which are basically the Pukinia fibers. It's just another name for it. But as you can see, it's in the name subendocardialis, so beneath the endocardium, which is also seen here, directly beneath it. And these are like the final destination of the of this current. It's basically yeah. So this serves basically as a cable. And now we have like, here's another overview. This shows that there are some ways that are quicker to the nodus atrioventricularis than others. Interestingly, there is nobody has an idea how it works. We just know that it works. Like, we don't know how the histology behind it is. We just know that there are some ways that the current is, that the conduction is faster than others. Okay, and finally, right down here we have like a simulation of a beating heart. You can see now that the atrium is first contracting and then the ventricles. But the ventricles are both contracting at the same time, more or less. And here we will also talk about the ECG, because it's like one of the clinical things that are actually very often used, and something that we will have like an example for physiology. Okay, ECG basically means electrocardiography, and I will explain a little bit how it works. So you basically try to read the depolarization of the electrical field. Here you create an artificial vector. This would be the minus, or rather the negative, and here would be the positive voltage. And here you can have like, here's the positive towards the positive side and towards the negative. And what happens now is, if you have like here the nodus sinoatrialis, and it depolarizes, this will be the negative towards the positive. So basically, this is what you will see on this ECG. I will explain now how the different stages. because this is actually like the different phases of the contraction of a heart on time, depicted in an ECG. So over here, first of all, you have a depolarization of the sinus atrialis, nodus sinoatrialis, and now it flows through the atrium, through the muscle tissue, towards the nodus atrioventricularis, and this would be the equivalent of that, the depolarization of the atrium. Then the nodus atrioventricularis blocks the depolarization for a short while over here, for like about 100 milliseconds, and only then it continues. And now we can actually see that the muscle tissue in between, in the septum interventricularis, is different from the crus dextrum and crus sinistrum, which are these modified cells which conduct the current, the voltage much quicker. So first, the voltage goes downwards, and then only the muscle tissue gets depolarized as well. And because it's faster this way on the sides, it will go upwards first, which causes this little Q spike. And because the depolarization is towards the other side of the vector now, it goes downwards. Only after then, you have like this classic huge R spike because of the depolarization directly towards the vector, towards the apex. Once you reach the apex, the only way to go is back towards the rest of the ventricle, towards the atrium. And this would cause the S spike downwards because, again, you work against the vector you created. Then you have the ST time, which is basically the time when everything, the entire ventricles, is depolarized, and there is no change at all. Like, you have like a little time where everything is contracted, and only then the repolarization happens. And again, this is happening from the apex towards the atrium. And that's why, although it's a repolarization, so technically the other way around that the depolarization works, this time it works toward the positive side because it's positive to negative, but against the vector that we created. So if you have any questions about this later on, I'm happy to answer. I know this is sometimes a little bit confusing, but I thought to give you like a little intercourse about what, for example, physiology would be about regarding the heart, and why, like, for example, these anatomical features are so impactful regarding the physiology and the actual function of the heart. So to clarify, the nodus sinoatrialis does get like modified by a shit ton of different pathways. So, for example, other nerves can intervene and cause at many different stages of the heart different, like, for example, it can slow down the pathway over here, or quicken, like make it faster. I will not dive into this. It's a lot, and this would be like diving into way too much physiology stuff. As the final two slides, I think, we will talk about a little bit, at last, about the coronary arteries, and this will be very rough though. because again, arteries do change, and this is like more an interesting overview than actually super interesting at all. So you have two main vessels, the Arteria coronaria dextra and the Arteria coronaria sinistra. One to the right and one to the left side of the heart. Both are responsible for several different areas of your heart, and this is in fact very interesting in the clinic because a heart attack basically means that a thrombus blockades one of these vessels. And in the respective area that these vessels supply will be, of course, be a necrosis because it's no the supply will be blocked. Sorry. So it's actually interesting to know what area is or normally what area is supplied by which vessel. Though, again, these are blood vessels, so it varies. Over here, it's of course, this is like a little bit German again, so I wrote the English version of it above. Basically, you have normally three different types of blood supply. You have a left, normal, and right version. The left and right just refers to which of these two blood vessels, the Arteria coronaria dextra and sinistra, are the main supply of the different areas. Though it's all, or normally always, that at least a little part of it is supplied by the other blood vessel. So normally it's like shared more or less between the Arteria coronaria dextra. You have here the yellow part from the dextra and the blue part from sinistra. And as you can see, there are variations where the left arteria with its branches is much more prominent than the right one, which is pushed away on to the very edge of the right ventricle. And the other version would be the very on contrary, where the left artery is very small and the right one is prominent. This can, of course, as well change if you, for example, have like a heart attack, sorry, and one of these areas is blocked. The other artery can try or will actually grow towards this area and try to supply it as well. But of course, this can only help so much, and especially in the acute situation. This is just like regarding the veins of the heart, much less important, and just like here as an overview, you have like these veins, the Vena Cava magna on the one side, and going into the Xenos Coronarius, which will lead into the right atrium, and will just join the other blood of the body. Again, there are some, like a little, which is actually interesting, there are some veins that directly go into the left ventricle, and this causes actually like a little bit of desoxygenized blood enter from the heart, will enter the oxygenized blood of your body in the left ventricle. And although it sounds very minuscule, you can measure that. I don't know the exact figures. It's not super important, but it's interesting. And on the final bits, this is something that is quite special about the heart. It has like a very quite high consumption of oxygen, especially like if you are currently working out. And the problem is that the oxygen extraction of the heart muscle is already very high. 60 to 70% is very, very high for any tissue. So normally for example, your muscles would just have a much lower extraction rate in when they don't have to do anything, and would just take more oxygen from the blood instead of like forcing more blood through the tissue. This cannot be done in the heart. You have to do what you have to do is you have to pump more blood through the vessels to get more oxygen to it. You can't just make the extraction higher. And what is also interesting is, due to the nature of the heart, whenever a heart contracts, so in the systole, the blood vessels, or rather these blood vessels, will be pressured and pressed out. So you have no way of actually supplying all the muscle tissue during a systole, and you have to wait for the diastole for the blood to flow through the coronary arteries. This is important because if you have a higher heart rate, the systole will have like a high percentage compared to the diastole phase, and this difference in percentage, how long it takes, will rise the higher the heart rate goes. So at some point, your heart cannot beat any faster because it's restricted by the fact that it simply won't have any blood anymore in its own blood vessels, in its vasa privata. So this is another restriction for the heart, so it can't beat like as fast as it wants to. Yeah, and that's a kitten with a heart. Basically, I'm finished. I hope I didn't fuck up my English too much, and you learned a little bit. And I will end the presentation now and ask if you have any questions, be free to ask. I hope I can at least help a little bit.
Thank you so much. That was a really great talk. If you have any questions, please post them in lectures, conferences, and FW will also answer them there. We'll be starting the next talk in about 20-ish minutes. Clockwork will be giving his presentation, so stay tuned. Thank you.
The way that I took so long, I kind of overdid it, even though I cut a lot of stuff, like for example histology. But yeah, sorry about that.
It's okay. Thank you.